To summarize the information provided in this chapter, diastolic function is common. The incidence has been reported to be as high as 20 to 40% or even higher. Diastolic function is important. Diastolic function largely reflects left ventricular filling pressure and thereby correlates well with symptoms and with the prognosis of patients. Echocardiography can help us determine diastolic function better than any other method. We can use several different echo modalities, such as the mitral valve inflow pattern, the flow propagation with color M mode, the pulmonic venous flow, and also tissue Doppler at the mitral valve annulus. Most important is the pulsed wave Doppler across the mitral valve, where we can look at the E to A ratio. We can grade diastolic function according to this pattern into a normal pattern, disturbed relaxation, pseudonormal pattern, restrictive filling pattern, and a so-called irreversible restrictive filling pattern. The pulsed wave Doppler, together with the tissue Doppler, can help us assess and quantify diastolic function. What else do you have to watch out for? Some patients have supranormal function. They have a pattern which looks very much like the restrictive filling pattern with a very tall E wave and a small A wave. This is caused by suction of blood into the left ventricle during early diastole. And look out for the so-called L wave, which is a third peak between the E and the A wave, which denotes elevated left ventricular filling pressure. You should always assess diastolic dysfunction in the context of the underlying pathology. Remember, all patients who have systolic dysfunction also have diastolic dysfunction. And finally, you can also assess diastolic dysfunction in patients who have atrial fibrillation, in particular by using the tissue Doppler, the E to E prime ratio.